Greetings, professors and doctors. I'm very glad to have the opportunity here in APCSS and ESA. I'm Sheng Huang, the neurosurgery resident from Zhonghua Christian Hospitals. I'm going to talk about the unique technique with the recent case for the revision cervical disc arthroplasty (CDA). And this presentation will focus on how this method can be applied during the operations and the concerns, the factors we involve in the revision CDS. So there's no conflict of interest. So the cervical disc herniation, which was caused by nucleus pulposus protrusions, it may be caused by degenerative change, trauma, physical conditions such as obesity, genetic factors, or abnormal structures. We often do the non-surgical treatment as the first line of the treatment, such as extractions, physical therapies, or pharmacotherapies. But if there is no response to the non-surgical treatment, or comes out with the severe neurological deficit, and the surgical intervention may be necessary, such as ACDF, CDA, and posterior nominal foraminotomy. Compared to ACDF, CDA has some sort of advantage, such as its ability to preserve natural neck motions, to avoid rigidities, to lower rates of adjacent segment disease, and revision rates. Thus, there is still 1.48% that need to be the revision. And revision surgical techniques such as ACDF, the most common choice, and posterior nominotomy, replacement, CDA, and combination anterior posterior fusion. And the replacement CDA is the least option because it's unpredictable conditions during the operations and the unclear outcomes, and these problems we will talk about later. So let's go through the case first. A 45-year-old female which suffered from neck and shoulder pain for several months, and neck pain with the radiations of right upper limb and numbness, right forearms, medial aspect with finger numbness. There's no forelimb weakness, no improvement in any position. And we can see the first MRI, there is still C5-6 and C6-7s, HIVD with foraminal stenosis, especially right side. So the first operation was done over C5-6 and C6-7 with CD8, but there's no improvement after operations. So she came to our hospitals and found out further MRI and CTs. We don't see CTs, there's too many artifacts. And the dynamic view, you can see there's no malpositions, no subsidence or migrations of previous artificial disc. And there is bilateral and incomplete decompressions UV joint over C5-6 and C6-7. And the reconstructive CT, you can see there's still foraminal stenosis over here. So we decided to arrange a revision CDA over C5-6 and C6-7. And there's the operation videos. First, exposure the previous artificial disc, remove the scar tissues, then we drill. We use the high-speed diamond bud. We don't destroy the bone. We destroy the artificial disc itself. We remove the anterior aspect, and then with enough space, we remove the core. As you can see, there are many metal fragments surrounding the soft tissue, so we suggest that you should put the paddings around the soft tissue to prevent the attachment of the metal fragments. Then we do the leverage technique. Just like leverage walking, when we have the enough space, you can use the osteotome, dissectors, or elevators to detach the artificial disc and the implant without marring or destroying the implant to preserve the implant. The upper part, remove it, and the lower part. After we remove the whole artificial disc, you can see there is the scarred posterior longitudinal ligament over here. And this is ossified scar tissue, scar PLL. We don't deal with it. We leave it alone to protect the dura. Then we continue do the bilateral UV joint decompressions. The right side and the left side. Then we do it in the hyperroom, so we use the artist Fino systems to do the intraoperative CTs, and you can see the bilateral complete decompression of UV joints. Then we put a new prosthesis inside the traverse and the new one. So this was the remove artificial disc. As you can see, we destroy the anterior aspect to have the enough space to remove the core, and that is 3 pieces of the artificial disc. After operations, and patient experience pain relief, although there is mild numbness, this is not a big problem. And she had a discharge 3 days after operations. So after 3 months, we follow the reconstructive CTs. There is relief from stenosis. And for 1 year's X-ray, cervical X-ray, there's no malpositions, no migrations, no subsidence. And the dynamic view shows the well positioned of the new artificial disc. So the discussions, we're going to talk about the leverage technique for the revision CDS and Huawei concerns. So we do the leverage technique. We only destroy the prosthesis. We leave the bone alone to preserve the maximum implant with minimal moulding. So it may decrease the post-operative subsidence and failure rate. And we remove the artificial disc like this, like leverage walking. And there is still some disadvantages. It was restricted by patient's conditions and artificial disc type. And furthermore, there will be some metal fragment attachment, but since it was made of titanium, this should be not a big problem. So the 2 main factors for the revision CDS of leverage techniques, one is patient's conditions and another is previous processes. So there are many causes that we should do the revision CDS, such as neck pain, inadequate initial decompressions, mechanical complications, ossifications, osteolytic lesions, and infections. As you can see, the first 2 main causes is migrations and neck pain. And we suggest that you shouldn't do the revision CDS with leverage technique to the osteolytic and infection lesions. Because there is no enough residual structures, no enough the implant. We can put the new one near the new artificial disc. So we don't recommend on the osteolytic lesion. And the second one is previous prosthesis. There's many prosthesis type, kills, non-kills. Whether we should mount the implant or not, or how many pieces of the artificial disc. So we don't recommend it with the previous artificial disc, such as 1 piece like M6 or brand disc, 2 pieces like prestige disc, because you have to remove many of the previous artificial disc to create enough space. And those who had huge kills, such as pro disc, also cure, because you don't have enough the residual implant to put the new one. So if the previous artificial disc with 3 pieces, such as pro disc, Mobi-C disc, and there's no cure or the mini cure, such as Discover disc and PCN, then you can do the revision CDA with leverage technique. So that's it. The leverage technique for revision CDS, we just deal with the prosthesis itself. We don't destroy the bone, we don't drill the bone, we leave the bone alone to preserve the maximum implants with minimal moulding, and it may decrease the post-operative subsidence and failure rate to preserve the neck motions. And you can do the revision CTA instead of the ACDF, but it's not suitable with osteolytic lesions or the infect lesions, and it may be restrictions of the artificial disc type, such as 3-piece. We suggest you do the leverage technique for the 3-piece design or the less implant prepare the disc. So less more cases we should do the long-term follow-up, such as failure rate, subsidence rates, or maybe different types of artificial disc that may be suitable for leverage technique. That's the end of my presentation. Thank you.
Thank you, Dr. Huang.